to today's webinar, An Attack on Women, the Intersection of Violence and Homelessness. I am Julie Hashida, and I will be the moderator for the webinar presented by the National Healthcare for the Homeless Council as part of our spring virtual training series, Her Health, Her Housing, with support from the Health Resources and Services Administration and the Bureau of Primary Health Care. This is a 60-minute webinar with the last 10 minutes reserved for Q&A. There is a chat box below the presentation slides for your questions or technical issues. So please type your questions or technical issues into that chat box at any time during the presentation. A select number of questions will be answered at the end of the presentation during the Q&A session. The remaining questions will be logged and provided to the presenters for a written response after the webinar. Also, if you're having technical issues, you may call Caroline at 615-226-2292 at extension 222, and she'll be able to help you through any technical issues that you're having. This session is accredited for 1 continuing medical education credit hour through Vanderbilt University Medical Center. If you plan on claiming credit, please copy the information located in the CME information notes pod at the end of the session and then follow the instructions. The claim code will only be available during this session and will appear in the last 20 minutes of the presentation. In order to receive credit, CMEs must be claimed within 3 days of the end of this presentation. All right, so I'm glad to introduce our speakers and presenters. So Amy Grissett. Amy Grissett is a married mother of 3 children and 2 stepchildren and grandmother to 6. Amy and her husband William have been married for 31 years. Amy and her family experienced homelessness for nearly 2 years after losing an airport shuttle business as a direct result of 9/11. Amy and her family were doubled up, housed in a hotel, and then in a family shelter where they received services through the Homeless Families Program at the Family Health Center of Worcester, Massachusetts. Once housed, Amy started to volunteer for that program as a way to give back and was hired after 3 months. She currently works in the maternal health program as the OB perinatal scheduler. In addition to her work at the health center, she is a past chair of the National Consumer Advisory Board and is the past secretary of the Board of Directors for the National Healthcare for the Homeless Council and currently serves on several council committees. And our next presenter, Amy Turk, as Chief Innovation Officer at Downtown Women's Center. Amy Turk provides strategic leadership in the development and implementation of new organizational projects and fosters vital relationships with community partners in efforts to end women's homelessness in Greater Los Angeles. Amy has worked in the homeless services and mental health field for 18 years, always with a focus on serving women experiencing homelessness. Amy is one of the founders of 1 in 4, a national social change movement to end homelessness among women, and the Domestic Violence Homeless Service Coalition, which is a Los Angeles County initiative to create a client-centered system that increases access to safe housing and supportive services for survivors of domestic violence. So our combined learning objectives for today's session is, well, first we would like to describe some past research so that we can better understand violence against women experiencing homelessness. Also describing programs that provide clinical services to address violence against women experiencing homelessness, and then a list of recommendations for caring and working with women experiencing homelessness. So today's topic on violence and homelessness reflects the complex challenges that women may face and the need to create services that are responsive to our clients' physical and psychological safety. In thinking about your role in this work, I'm proposing that you all in our audience today think creatively about how we can take what we hear and learn on the webinar and infuse that in our work, in our day-to-day activities. We know that there's representation not only across the country, but also across different disciplines and agency types. And if nothing else, as we move forward, we want to be considering the risk of violence as an inherent threat to our clients' experience. And I know there's so much to cover in this topic of violence and homelessness, and we only have an hour. So again, I'm encouraging you all, if you have any questions or thoughts or comments that you'd like to share, please continue to submit those through the Q&A pod. Those go directly to our presenters. And so during the Q&A session, we can have more of a dialogue with our presenters on this topic. And I'm really thrilled to have our invited speakers today because they represent some important sectors of our work in healthcare for the homeless. Healthcare for the homeless is more than just clinical services and direct care with the primary driving force of everything else. You know, caring for people is what we do, but there's so much that goes into that. For instance, studying how to best care for people, learning best practices through research, and how to translate research into policy. Also, just having a better understanding of the implications of current policies, such as those that, you know, essentially criminalize homelessness. And specific to this webinar, how those policies further put people at risk for violence. Understanding policy can have a direct impact on our work. We are also encouraging you all to be thinking about the philosophy behind our programs and how that translates into practices for our executive directors and our managers in the administration of our programs, as well as the supervision of our clinicians. And so the council, finally, the council is a passionate advocate for the consumer voice. And when we think about consumer involvement, we really mean that in all aspects of our work. So not only in the governance of health centers, which is funding, which is mandated by the 330 program, or even the role of consumers in clinical services, which we know is a best practice, that's something that we see with, for example, the community health worker programs. But we are also determined to include the consumer perspective in policy and research. The relationship between violence and homelessness is what we'll be exploring today. And so one of the studies that we'll look at is the one conducted and published with council staff in 2014. And our next speaker, Amy Grissett, will go into a little bit more depth on. But in that study, the literature showed that the prevalence of violence victimization in homeless populations is estimated to range from 14 to 21%. Interestingly, in the study, with approximately 500 participants and people experiencing homelessness, about half of those participants reported experiencing a violent incident while homeless. And research has also shown that there are some experiences that are unique to homelessness that put individuals at even more risk of violence. So for example, those who have been previously turned away from a shelter are significantly more likely to experience victimization. And then of course, the central theme of the Council Spring Virtual Training this year, being a woman, and so in the 2014 findings, it supported the development of preventive and treatment interventions specific to women. So certain subpopulations and experiences are critical for us to study, to better understand, to research, and also to respond to, so to develop interventions for. And we have some general ideas about the physical and psychological consequences of violence, but then augment that with the experiences of homelessness, and then consider how that may impact how our clients access care. And so finally, one of the recommendations that we'd like to highlight, and that was highlighted in the study, is the need for more collaboration between public health agencies, homeless service providers, and women and family service entities, specifically to address and prevent rape against individuals experiencing homelessness. And across the board, interdisciplinary partnerships have been demonstrated to promote long-term health on both individual and community levels, but with today's topic, we're strongly advocating for those wraparound, comprehensive services that can help prevent and, if necessary, identify and treat sexual assault and the long-term suffering associated with this type of victimization. So I'm going to stop there and pass it on to our next presenter, Amy Grissett.
Thanks, Julie. Welcome, everyone. Thanks for joining us today for this really important topic. I wanted to give you a little background about the National Consumer Advisory Board, also known as NCAB, formed in 2003 out of a conversation about how important it was to have the consumer voice at the table. And I did have a typo here. There were 4 original steering committee members in 2003, and then I attended my first conference in 2004 and was elected onto the steering committee. The present steering committee actually has grown over the years, so there are now 12 members of the steering committee, which include a chair, 2 co-chairs, members at large, regional reps, so it's really grown. And it's more inclusive than it was in the past. Also wanted to give you a little bit of history about what we do out in the community. So NCAB felt like we as steering committee members represent other voices that are not able to be at the table, and that we should be talking to those people on a regular basis. And so we contracted with Paul Bowden, who was the former director of the Homeless Coalition in San Francisco and had been doing a lot of outreach. And he came to several meetings over a couple of years and taught us about reaching out to consumers and doing these surveys that we continue to do today. Some of our previous consumer participation surveys have been on safety, they've been on access to care, on hard-to-reach patients, so a range of topics. And then we decided to do something on violence, and as the chair, I had a real interest in research and had been involved in a couple of homeless research projects. And so we started having a conversation about whether or not this could be an actual research study. Currently, we haven't done a CPO in a couple of years, but the steering committee will be meeting in Nashville in October and discuss topics that they might want to explore. So again, we had a meeting in San Francisco for some of the research team from the council, and decided to move forward with a research study. So the steering committee developed a list of survey questions, and then we developed a consent form. And then we also thought it was really important for people to have a list of local community resources, because some of these questions we felt like would bring up trauma for folks, and we didn't want people kind of left out there with out resources or people to talk to if it did trigger some of those past traumas. We felt that was really important. So at the time, there were 5 steering committee members, and so those participating sites listed are where the steering committee members were from. You see Worcester at the end of that list. And then we did an application to an IRB, which was the Nashville Metro Health Department. And it took some time. This isn't a quick process, so it does take a little bit of time to get it approved. And as we were going through that process, things were brought back to the steering committee, and we reviewed everything. And then we got talking to our local cabs. So we wanted to engage consumers of the local cabs to go out and actually administer the surveys. And some kind of did it on their own. They knew where people were out in the communities, but other consumers teamed up with outreach workers and went out and talked to people that way. The only criteria for participating in the study was that you needed to be 18 years or older, formerly or currently homeless, or use services at a Healthcare for the Homeless program. My role on the study, like I said, I was chair of NCAB at the time. There was a conversation with a couple of the research team to see whether or not I would be interested in being a co-investigator, which I was, and so I did the city certification to become an investigator on a research study, which the council actually offers that city certification for anybody that's interested. And then the analysis and dissemination was done by the council. So all of the surveys got turned in at the end of the time, and those went to Molly Mindbreeze, who oversaw the project, and Darlene Jenkins, who's the director of policy, and then also Lauren Brinkley Rubenstein from Vanderbilt. And then they disseminated the data, and then we sent site-specific data to each of those sites so they can come up with some strategies on how to proceed with the findings. We did decide that it was important enough for us to write an article. The council staff were the ones that put that article together, but once again, the drafts came to the NCAB steering committee, and we all commented, and we had lots of revisions. And once we felt like we had a good article, we submitted it to the Journal of Violence and Victims, and it was accepted and published in 2014. And as you see, there's a list of authors there. So Molly Mindbreeze and Lauren Brinkley, but everyone under that, up to Darlene Jenkins, are all consumers that were involved in the study. So some of the results, I just wanted to highlight a few, and Julie mentioned this when she was talking, that half of the participants reported being the victim of a violent attack while homeless. Those who have been homeless for a longer time and are older in age were most likely to experience violence. And I think probably everyone would agree that women are more likely to experience rape. What was really different from some of the other studies about violence in women out there is that rape by a stranger for a homeless woman was was by a stranger, when in other studies it shows that the victim knew their attacker. So this was saying something a little different than what was being said in other studies. So we found that to be pretty striking. And then some of the recommendations, and Julie also mentioned one of these, homeless healthcare providers should increase screening for experiences of violence during primary care visits, provide victimization prevention programs, I think that's what Julie was talking about, increased outreach to patients less likely to access primary care. As we know, there's a lot of people out there who don't want to come in, but it's really important that we're able to reach them. Screening for trauma and using trauma-informed approaches. Increased access to STD and pregnancy tests for women who are victims of sexual assault. And agencies who provide services to women should provide wraparound comprehensive services that can help prevent and, if necessary, identify and treat sexual assault and the long-term suffering associated with that victimization. And I am going to turn this over to Amy Turk.
Thank you so much, Amy Grisette, and thank you, Julie, and to the National Healthcare for the Homeless Council for putting on this series of webinars to help raise the topic of women's homelessness and intersectionality. Downtown Women's Center is located in Los Angeles, and we provide an array of services to over 3,000 women each year, including a safe space for women to access basic needs services, such as meals and showers, and most importantly, permanent housing. We provide permanent housing on-site and within the community. We integrate healthcare and mental health services throughout our programs, and we partner with a FQHC to run the only women's health clinic in our area. We also provide linkage to job training, competitive employment placement, and the women health staff are on-site and web-based social enterprise, which is called Made by Downtown Women's Center. They make lovely products that are both sold in our stores and sold online. So for a little context of who is experiencing homelessness from a gendered lens in Los Angeles, in our last point in time count, 31% of the overall population experiencing homelessness were women. In our community, in the Skid Row community of downtown Los Angeles, that number increased by 35% from 2017 to 2018. However, there was a slight decrease across the county. And just for national perspective, in the last 3 years, HUD has reported that of the overall population of people experiencing homelessness, 39% are women. In our local count, 30%, and this is men and women, this is not deaggregated by gender, 30% stated that they had experienced domestic violence over the course of their lifetime, and 6% cited domestic violence as the reason for their homelessness experience. And these stats here are the extent of the information related to women and intersectionality that comes out of our point-in-time count and our demographic survey as supported by HUD. So Downtown Women's Center has taken it upon ourselves to dive deeper into women's homelessness since 2001. We have produced 5 community-based research assessments in order to demonstrate how homelessness impacts women at multiple levels. Like I said, we do this report every 3 years. It sounds like the same methodology that Amy before me discussed in her survey research. We do this in collaboration with what's called the Downtown Women's Action Coalition, a coalition of community members dedicated to helping solve homelessness for women. And this is, again, community-based research that looks at the needs, the characteristics, and conditions facing homeless and low-income women living in our community. In this last report, we included longitudinal analysis over the past surveys with conclusions from the 371 surveys that were collected during this report. We've also helped other communities conduct a similar report, namely in Chicago and in Washington, D.C., and we're happy to provide some technical assistance. We find this is one of the best ways to make policy change with this information. So what we found in our report is probably not surprising and certainly matches the previous report findings. Violent trauma is one of the most persistent, ongoing factors affecting women experiencing homelessness. More than 90% of respondents experience physical or sexual violence in their lifetime. For many women, this violence is not just one instance, but rather an ongoing reality. Nearly half of all survey respondents had experienced violence within the last 12 months. Of those who had experienced violence within the last year, nearly half of them had experienced violence at least 4 times within that last year. Women surveyed experienced sexual assault at a rate nearly twice that of the general population. So women that may not be experiencing homelessness, about 20% report sexual assault over the course of their lifetime. But by contrast, more than 1/3 of women in Skid Row, 40%, experience sexual assault at some point in their lifetime. Demographic trends among women in our community depict the long-term traumatic effects of systemic racism. The needs assessment data show that African American women are significantly overrepresented in the homeless population. Our census data in Los Angeles County shows that there are African American women make up 8.7% of the population. Yet African American women comprised almost 60% of our needs assessment respondents of women living homeless in our community. And this is not just a trend that's happening in Los Angeles. These stats bear out nationwide that people of color are disproportionately overrepresented across the nation in all of our homeless stats. But what we found staggering is that African American women were more likely to experience violence. 40% experienced sexual assault, domestic violence, or interpersonal violence within the last year compared to 27% of white respondents. Our data also show that many women living in our community feel unsafe and face re-traumatization in the very services meant to help them, such as emergency shelter or transitional housing. Of women who said they had experienced these services, nearly 1/3 reported feeling unsafe in shelters, and just over 30% said shelter staff did not treat them with respect. Disturbingly, of women who slept most frequently in shelters, more than 1/3 had experienced physical or sexual violence within the last year. We don't know if that happened in the shelters or not, but that was reported that in some location they had experienced sexual assault. And so our main response to the needs that are expressed through this research is to employ trauma-informed care. Even though the majority of women experiencing homelessness have experienced some form of trauma during their lifetimes, our data reflects a severe lack of trauma recovery resources in our community. More than half of the respondents reported not receiving services to deal with the after effects of trauma because the staggeringly high prevalence of violence is the most distinguishing difference between women and men experiencing homelessness. Homeless service providers must be trained in trauma-informed care, including cultural and gender competency training or humility training to ensure women are connected with recovery services. And so utilizing the Substance Abuse and Mental Health Services Administration's work, which is free to download on their website, we've dug into this research here called Tip 57. Again, it's free for anyone. And we're really embracing what they call the 4 R's, which is realizing that trauma is widespread. And in our work, it's not just confined to the mental health departments, that everyone in the organization needs to be able to realize the signs and symptoms of trauma. So recognizing the signs and symptoms of trauma in those that we serve is very important for trauma-informed responsiveness. So in the 4 R's, being able to respond appropriately to what looks like signs and symptoms of trauma is really important. And this is important for all staff at all levels of an organization, that we learn to change our language, our behavior, that we adjust our policies to take into consideration the experience of trauma. And that we do everything possible to resist re-traumatization in all of our services. So could we reduce barriers to get someone into an intake? Could we extend shelter time because we're working hard on finding permanent housing? Could we limit unnecessary exits from shelters? Just examples of things that we have power over to resist re-traumatization. And the main takeaway, the main thing to understand of trauma-informed care is that it's changing a paradigm in your brain from a perspective of what's wrong with you when you see that someone might be going through something to a perspective of what happened to you. And we find that shift in our thinking helps us respond in a more trauma-informed way. But trauma doesn't just, as I'm sure you know, doesn't just happen to the individual. Realizing and recognizing cultural and community trauma is critical in trauma and resiliency-informed care organization. Women not only experience traumas inflicted in individual relationships, such as those through child abuse or domestic violence, they also experience trauma in the context of what SAMHSA identifies as the sixth principle of trauma-informed care, which is understanding people through a cultural and historical and gender lens. And due to historical traumas related to things like societal racism, sexism, homophobia, and overall marginalization, women impacted by homelessness experience trauma related to systems that, for example, block access to jobs that pay equal to men, or block access to housing in neighborhoods they feel safe in or connected to good school systems, or block healthcare that is gender specific. One way we address this is to offer awareness-raising opportunities, and much like the Council values the voice of lived experience, we too have advocates programs and ways to empower people with lived experience to help change these systems. And so because trauma-informed care is a little, in some cases, new to people, and it's much of a philosophy, not really a science, we took it upon ourselves to write a trauma and resiliency-informed care toolkit for homeless service providers. And the biggest takeaway is that trauma and resiliency-informed care is more of a journey. It's not a destination. There's no perfect checklist or even certifications out there to make sure that we're doing this perfectly. But it helps us respond as well as possible to individuals surviving trauma. And it helps us continuously improve the conditions of our services and how we respond to these individuals. All these needs, all the needs of people coming to us who have lived through trauma are nearly impossible to anticipate and plan for. However, creating a trauma-informed care foundation will help organizations be as nimble as possible to provide the best care for individuals experiencing homelessness. This is on our website and included in your resources here on this training. So in addition to our work to help other organizations become more trauma-informed, we have also created opportunities for systems change work through coalition building. In our community, we noticed that women were slipping in the gaps between two very siloed systems of care, that of the domestic violence system and that of the homeless services system. So we created this coalition to help create a client-centered system that increases access to safe housing and supportive services for survivors at this intersection. And so in the last 2 years of this coalition building, which we've talked to similar communities across the nation and have seen where their coalitions have helped this intersection as well, or maybe they're even thinking about starting their own type of coalition like this. But ours has really brought together community advocates, staff at homeless services and domestic violence services, and in government roles. In fact, we have about 400 members in 80 different organizations. And in that, we've helped demystify our systems. We've helped build trust in our partnerships and done a lot of cross-training. But at the forefront, we have ensured that survivors' voices are in every discussion and decision point. We have survivors represented in our core leadership team, in every work group, and participating in our advocates program. The advocates helped lead another community-based research opportunity, which resulted in what I'll talk about in the next 2 slides, the Domestic Violence Homeless Services Coalition's Focus Group Report. So in this report, we conducted 12 focus groups across our county with women that were at an intersection of housing instability and domestic violence, 81 women in total. And the highlights of what they shared with us demonstrated that many felt re-traumatized in the process of finding the services that they needed. and that they often felt like they had to alter their stories in order to get help. So for a domestic violence service, that meant stating that the violence might have happened sooner, more imminently than it actually had. And for homeless services, it had been sharing details or omitting details about their homeless status so that they would qualify as chronically homeless, which in our system opens up you to more permanent housing subsidies and opportunities. Participants recounted feeling judged and dismissed, and in some cases turned away from engaging within the system for help when they just felt helpless. But folks that did connect to the right services, after, and all of them expressed that it took a long time, but once they found really good trauma-informed services, namely mental health services, they saw how their life could get better. And so we've been taking the recommendations that came directly from their voices and advocating for increasing permanent housing solutions, namely for more housing solutions that look like rapid rehousing or flexible funding, to nimbly respond to their housing needs, to help prevent eviction or to get them the funds for a few months, which in some cases is all they need. We've been advocating to increase the sector's understanding of trauma and its impact, to increase advocacy and education, and to provide reasonable accommodations when possible, namely for translation services for really complex systems like legal or medical matters, and helping people who do not have documentation, and providing technical assistance for providers to be more culturally aware and culturally humble. And so here are a few resources to leave you with as well. The slides will be given to you on the webinar, and I'd like to pass my part back to Julie.
Great, thank you. And before we move into the Q&A, just want to share a couple of additional resources and remind you all that the recording and the PowerPoint slides will be available to download, so you will have access to all of this. But just a couple of resources from the National Healthcare for the Homeless Council. This page, the Consumer Participation Outreach Reports and Recommendations, those are the studies that Amy Grissett had shared, but these are a list of some of those reports and recommendations that are available on our website. And then we also have a toolkit for responding to intimate partner violence, again, also on our website. So I believe you could just click on the link in these slides now, but again, you can download the PowerPoint after today. So we did receive several comments, some prompts for Q&A. So we will spend the rest of the time responding to your questions, so please continue to submit those. And let's see. Well, oh, also, I'm sorry, one reminder about the CME claim code. So as you can see, it was just posted on your screen. And remember, it's only available during this session. So if you're planning to claim credit, please make note of this code. Okay, so the first question I'd like to ask both Amy's, if you all have thoughts or experiences around screening. The question is about, your experiences with screening. It was specific to trauma, but maybe if you have thoughts about screening for violence or trauma. And also, there's some conversations in the trauma-informed circles around the difference between screening and assessment. There's sometimes this push to do universal screening as part of a trauma-informed care, and some concern around that. But I think one of the responses to that concern is that, there's a difference between screening and assessment. You know, assessment is a little bit more in-depth to understand the trauma, and but in any case, whether you're screening or doing assessment, you know, we want to be careful not to re-traumatize, but also have resources in place to respond to an affirmation or positive response when someone says, yes, I've experienced trauma, or I'm currently in, you know, a relationship, or currently experiencing violence in my intimate relationship. So we want to have some resources and things in place when we do screening and assessment. But I'm going to see if Amy Grissett, if you had thoughts, we can start with you before we go to Amy Turk, but thoughts about or what you all do maybe at Family Health Center around screening for either trauma or violence.
So on a personal note, I remember when we got referred to the Homeless Families Program. We were in a shelter at the time, and we were receiving some services there, but really the Homeless Families Program is what helped us get stable in the community. And it was a pretty comprehensive intake process, and one of the tools they use is the PHQ-9. And we did, you know, we did get into trauma. We did get into those kinds of subjects. And I know that we have advocates in our Homeless Families programs who actually do visits to moms, women in shelter, and they have an open dialogue with the shelter staff, which is great.
This is Amy Turk. I think, you know, given our awareness on this topic and all the research that's available, we try to assume, we assume that every woman that walks into our service has been through some type of gender-based violence. And so I think that, you know, that informs how we create a welcoming atmosphere and invite people in, and how we design the building and engage with people. And so sometimes we don't feel the need to ask that many questions if it feels more trauma-informed. But when we do screening, we do use the PHQ-9 that you mentioned. Our whole continuum of care is exploring using the danger assessment for clinicians, also called DA5. But the thing that we need to also work on at the same time is training people for, as was mentioned, what to do when the answers are yes, and how to make sure that they are, transferred to folks or given proper assessments and provided the right responsive services. So some people in our community are a little bit concerned about asking these questions because what if we don't have the right response? And so that's just something that we're talking about, but speaks to the need for really good training of our workforce so that we all know what to do.
Great, thank you. And you two both touched on some other topics that the questions are referencing, but we'll move down the line of the questions
Julie.
in order. Yes.
Yeah, I just wanted to respond just briefly about you mentioning resources. That's exactly the reason why we felt it was important when we were going out to talk to people about violence, that they have a list of resources from their local community to access in case they were triggered or re-traumatized. And then I wanted to speak a little bit to trauma-informed care, and it's something I've been talking about in our organization for a couple of years. Being around the council for so many years, it's a part of the work that they do, and so I felt it was really important to bring it to the health center. And so actually last week at our staff meeting, I did a little 15-minute snapshot into what that could look like for staff here, and we're going to have a much bigger training in the future so that we can become a trauma-informed organization. So I'm very excited about that.
Awesome. Awesome. All right. So let's see. And folks are continuing to submit several questions and even resources that they'd like us to pass on to the rest of the audience. So we will try to get through all of this. So yes, please continue to submit your questions and comments. Okay, great. So the next topic is the difference in treatment and care for women with and without children. So I don't know if either Amy's in your programs, if you all have different programming for women with children, with families, married and maybe married to men, if those services look different than a single women. There was also another question, sort of related, about developmental stage. So do you all have different services for women who maybe 18 to 24, at a different developmental stage than, women in their 40s or 50s, or is it all sort of, the same types of services for these women? And I'll let whoever would like to speak first on that.
This is Amy G. So we service women with children in our homeless program. We are a community health center, so we do have primary care here as well. But across the street from us is Community Health Link, and they take care of single adults. So I wouldn't really be able to speak to the difference.
I think from our perspective, it's about making sure that we have social worker support and case management support to make sure that everyone's getting the right resources that they need. We are a service only for unaccompanied women, but all of the women, or a majority of the women, have children. They're usually children that are living on their own or maybe in the care of others or in foster care or those systems. So it's really about, amassing all the resources possible and individualizing to them. And certainly understanding different developmental stages is something we talk about all the time. We're mostly seeing older women, and by older I mean, late 40s, 50s, 60s, and why we use the term older is that they're presenting with geriatric health conditions that are not otherwise seen until someone's in their 80s or 90s. And so we, really start to do geriatric health screenings at those ages. And then for younger, it's, also understanding how trauma impacts the brain, for everyone, how trauma impacts the brain, and how that impacts, decision making, and trying to create services that understand that a youth who's, transitional age youth is already, even if they weren't experiencing homelessness, is already still developing, and then adding layers of trauma onto that, understanding where they're coming from, is really important.
And I think that also highlights one of the principles in trauma-informed care around culture, and the developmental stage is also part of one's identity and culture. So I think just having that cultural sensitivity and humility kind of plays a role with the trauma piece. So we'll move on to the next prompt or question, and Amy G had alluded to this, but having one type of program or site that focuses on a particular population, but having a great relationship with, the health center across the street, and that health center across the street may provide services to another population within people experiencing homelessness. But this question is about shelters and collaboration between a health center and a shelter. And I think so this health center has a relationship with their local shelter, but they think that the shelter staff may not have the same, healthcare training or the kind of training that our health center providers have. So do you all have any tips on better ways for a health center to collaborate with a shelter in providing care for women experiencing homelessness?
This is Amy Turk. Something that we did throughout all of last year was just refreshed our relationships with the top 5 shelters that we refer our women to. As staff change, it's very easy to lose partnerships and easy communication channels. So our leadership team met with their leadership teams, and we developed informal agreements with each other to talk about how we could communicate if challenges arose, how we would handle confidentiality or being mindful of that, and how we could communicate successes as well. And we just wanted to open up communication. And there were we were going in with preconceived notions and hearing what the women were saying about shelters. So we wanted to try to improve it in that way. And then we have been providing free training on trauma-informed care to organizations that we find are the least trauma-informed, which is something that our leadership decided we could put a little of our energy towards because we thought it would benefit the women the most.
And I would just follow up with what I was saying before, is that our advocates do have an open dialogue with shelter staff, although we don't have a lot of family shelters in Worcester, and unfortunately what happens is people get placed out of the area or they get placed in hotels, but the advocates will then go out to the hotels and connect with people as well.
All right, great. And okay, we'll move on to the next prompt, which I think could be a little controversial. And I know there are a couple of resources that are out there that respond to the issue around perpetrators and perpetrators of violence. And if those perpetrators are people experiencing homelessness, and they may be in relationships with our clients, how does that affect their treatment in our program? So I'll just mention a couple of resources and before I pass it on to the presenters to respond. But on this page, the Responding to Intimate Partner Violence, that resources has some thoughts around working with the perpetrators. But also one of our partners, I believe they're also on today's webinar as an audience member, Futures Without Violence. So they have partnered with the council in the past, but they have lots of resources on this topic. And thank you to Hannah, our tech support, Hannah Sadler, our tech support at the council on this webinar. She posted this in the online resources pod. So you'll see Futures Without Violence Toolkit. She just did that right now. Thank you, Hannah. So you can click on that and see those resources from them. They do a lot with the health centers and community health centers as well. But so I'll see if you all, Amy's, have thoughts on working with perpetrators.
Yeah, so some of the questions, we had a few questions in the violence study that talked about the Crime Victims Fund and whether people had heard about it in their state or whether or not they were able to access it. And we've found, and that is out of the Office of Justice Programs, the Office for Victims of Crime. And we found that the whole process of trying to get compensated from the Crime Victims Fund was very cumbersome. A lot of red tape, a lot of paperwork. And so most victims were, they didn't want to deal with it because it was going to be a long process. So that is a resource. They do have information that's available through the Crime Victims Fund, educational materials that they provide for people. So I don't know if, Hannah, you're able to access their link, but I'm sure you find a lot of really good resources there as well.
Yeah, I think certainly if we can, we're providing a lot of education to the survivor as much as possible and helping, follow with providing her options, following her lead on how she wants to handle it. We're not a secure site, sort of traditional domestic violence location. We're an open address, so we have a lot of our own internal safety policies and ways that staff, look out for safety concerns. And in a place for all women, sometimes women come in with interpersonal violence relationships here, and so we try to, speak with women who might be in relationship here individually and help them assess their options. And so I would say it's really individual based. If it's safe and possible, it's not out of the realm of possibility that we would give referrals to people that would be considered perpetrators, but not necessarily, we don't serve people that identify as men inside our buildings.
All right. So thank you to our presenters, and for folks who are submitting comments in the Q&A pod. If you still have some unanswered questions or something you would like to share with our presenters, please keep submitting those. We will respond to you in writing following today's webinar. But at this point, I want to thank our presenters. They share a unique, helpful perspective on this topic. And also want to thank you all, our attendees, for joining the webinar. We had a great turnout, great high numbers in registration, and you all are very active and engaged in this conversation, submitting your questions, submitting your thoughts, sharing additional resources. We've added 3 or 4 extra resources during the presentation, during the webinar, and so that's great. We really appreciate you all. A reminder that the link for the archive webinar will be on our website at www.nhchc.org. That will be posted at the end of the virtual training series, so at the end of this month. And again, a reminder about the CME credit. Please copy and follow the instructions to claim the CME credit for this session. It's on your screen right now. That code is only available now. And the credit must be claimed within 3 days. Also, lastly, an evaluation of today's presentation should automatically appear in your browser when the webinar closes. So we're asking that you take the time to give honest feedback about your experience today on the webinar. We take that feedback and we try to improve our processes and improve your experience, your learning experience in following webinars. So please respond to that evaluation and submit some feedback. If that evaluation doesn't automatically open in your web browser, there will be that link on the screen. So just copy and paste that link on the closing page to access the evaluation. Again, thank you so much to our presenters. Thank you to you all, our audience, our tech support, council staff who's helping put together this presentation. We really appreciate your time today. And at this point, I'm going to go ahead and close today's webinar. Thanks.